Be doing an informational hearing, making healthcare affordable and what's driving cost up. First of all, let me welcome everyone, and for those who I haven't had the opportunity to see as we got back, Happy New Year. I'm ecstatic and very happy to be chair of the Senate Health Committee again as we undertake another 2-year legislative cycle. For me, the absolute most important thing is the successful implementation of the Affordable Care Act. California has done an incredible job. We are light years ahead of the rest of the country. We're now in our second enrollment, covered California. A third of our population is going to be getting Medi-Cal. California was the first state to have the Medicaid, or one of the few states that had Medicaid expansion. We're just way ahead of the curve. Other areas that are of great concern to me, obviously, is capacity, workforce, and the ability for patients to see a doctor. But just as important, if not more, is the cost of that health care to the consumer. And now that we are going to be requiring that every single person in this state either purchase or have health care through Medi-Cal, it is incumbent upon government to make sure that we're giving them the absolute best price. The consumer is aware, and when I speak on a regular basis to Peter Lee from Covered California, he no doubtly always says that the #1 concern of the consumer is the price point. So this is the second of a series of informational hearings we've had. The last one we had last year, and from that, we gathered a lot of information. We were able to come up with information that would allow us to shape policy to make sure that we have control our costs within our healthcare system. One of them that came out of it was the introduction of a bill I'm going to be doing this year, which is the All Payers Database. And the goal of this hearing is to find out what is it that the concerns that we have for this particular area that we're going to be discussing, and what is it that we can do in government to make sure that we can control costs, but more importantly, what are the cost drivers? So this will be just one of several. Obviously, we want to have the public involved. We'll encourage the public in other meetings to be part of panels and make sure that everyone is engaged. But more importantly, I hope that we can gather information today to make policy decisions that will affect the successful implementation of the Affordable Care Act, but more importantly, that everyone in the state of California, and as well as the state of California within government, whether it's Medi-Cal or our prison systems, we have the ability to make sure that we can control cost. I'd also like to take this opportunity to #1, congratulate, but also welcome my Vice Chair, Senator Nguyen, to the podium. She is now serving in the State Senate, coming from Orange County and the County Board of Supervisors. So at this point, I'd like to turn it over to her, see if she'd like to make any opening remarks, and then we will get started on item #2 when she's done. Anyway. Good afternoon, welcome, and please feel free to make some opening remarks.
Thank you, Chairman Hernandez, for holding this hearing on making healthcare affordable, what's driving the costs. Although I was not a member of the legislature when the Affordable Care Act became law, like many Americans, I followed the debate very closely and the events following its enactment. And like many Americans, I heard the president's promises to expand coverage, reduce costs, improve care, and allow Americans to keep the plans and doctors they like. Healthcare reform made many promises. However, Californians have not only seen through an expanded coverage, mostly through Medi-Cal. Therefore, this hearing on making healthcare affordable is timely and extremely necessary. While I understand today's hearing will only focus on a few issues, given this trend in rising costs, it is critical, though, that we understand what those increased healthcare expenditures represent. Prior to serving and joining the Senate, I serve as the county supervisor. In that capacity, as some of you might know, I served on CalOptima, which is Orange County organized health system. There, I was able to witness firsthand the difficulties that our local agencies go through to serve our residents. My mission as a county supervisor then and as a senator now is to ensure that we provide our residents access to quality health care in a cost-effective way. And so what you mentioned, Mr. Chairman, that consumers' concern is cost, but I think we also need to remember that having access and the quality health care to cure whatever it is necessary for them is also very important. Unfortunately, there are many factors that can hamper this process. The lack of accurate providers' reimbursement rates, for example, is causing access of issues for many communities like those in my district, making their underserved classification even worse. California has been short-sighted by cutting reimbursement rates, which has now shifted patients to higher cost alternatives like the emergency rooms. Has this played a role in rising healthcare costs? Should be something we looked at. As a steward of the public, I firmly believe that we need to provide our residents with access to health care, quality health care, but I also believe that we need to be vigilant of how we spend taxpayers' dollars. So I seek your input on the distribution of the cost increases that we are seeing and how we can contain these costs in a manner that will not affect our residents. On a personal note, I've always been a very big advocate for preventive care. So I believe preventive dental, vision, medical services are all equally important. I have promoted providing these services for many years. So I'm also interested in hearing the cost differences if we do preventive care versus not spending the money for preventive care. Whether doing preventive care for $10 versus $2,000 to the hospital, what would be worth it? So I know Chairman Hernandez and members of this committee share these concerns, and I look forward to our joint legislative discussion on Medi-Cal rates on March 4th as well. Again, thank you, Mr. Chairman, for this opportunity.
Thank you. We're going to now move on to item number 2. It's payers' perspective. The first individual that will come up and speak is Mary Cantwell, Chief Deputy Director, DHCS Healthcare Programs. Good afternoon. Welcome.
Thank you, Chair and members. Happy to be here today. So I'm here to talk about what we see are the cost drivers that are occurring in the Medi-Cal program. I actually think the background paper did an excellent job of really laying out the core issues that are facing both the Medicaid program as well as other healthcare payers. We do face similar challenges to other payers, but we also have some unique challenges given the population that we serve and the rules that we operate under. Medi-Cal, as you are well aware, is a program that covers low-income children, adults, and families, as well as seniors and persons with disabilities and low-income Medicare individuals. Given our particular population, the acuity skews to the high end, and we often take care of some of the sickest and medically neediest individuals. For example, according to the California Health Interview Survey, for the non-elderly population on Medi-Cal, they are more than twice as likely to report fair or poor health compared to all other individuals with coverage at a rate of 22% versus 10%. They are also twice as likely to report having a disability at a rate of 45% to 21%. They also report a higher prevalence of chronic disease such as heart disease and diabetes, and are much more likely to report mental health and substance use disorder issues. As we've discussed in the past, the vast majority of our Medi-Cal population is enrolled in managed care, so I will be focusing mostly on the cost drivers we are seeing generally in our Medi-Cal managed care program. And I know Ms. Shin, who's the CEO of one of our health plans, will be also talking about this issue later on in the panel. When we first look at the cost increases in our Medi-Cal managed care program, we notice a few things. First, since we have had transitions of higher acuity populations out of fee-for-service and into managed care, that in and of itself has driven cost increases in our managed care program with some corresponding decreases in the fee-for-service program. Second, as the Medi-Cal expansion occurred in January of 2014 to low-income childless adults and parent and caretaker relatives, we've also seen higher costs in our program. Overall, we see that this population is actually more costly than other non-disabled adults who have been previously eligible. We see this as driven by two key factors. One, pent-up demand from unmet need that we believe will be mitigated over time as they have access to care. And secondly, this population actually generally tends to be older and more male than our population that was previously eligible. We've also seen the addition of new benefits and the transition of benefits from fee-for-service to managed care. When accounting for these changes, we have seen our average managed care rates increase significantly over the last few years. But that doesn't necessarily mean that overall our healthcare costs are increasing, just that Medi-Cal, and more specifically our managed care program, is bearing an increasing responsibility for the services and the populations. What's important to note, though, is that overall, we see that our managed care plans have been able to, over time, impact the utilizations of services in a positive way. Through care coordination and management, we are seeing an increase in primary and other ambulatory care and corresponding decreases in emergency room utilization and unnecessary inpatient stays. So when we take a deeper look at the underlying cost drivers, taking into account the issues I've just raised, this is what we see. Unit cost prices for facilities and other providers are increasing, while utilization is actually remaining mostly constant. Now, we believe that there are likely two drivers of this. First, to the degree care management is impacting higher cost facility care by preventing unnecessary facility stays. For example, you would expect that the remaining unit cost would actually be higher because the population that's remaining in using those services is a higher acuity population. And so we do think that's some of what we're seeing, that those individuals who are needing hospitalization and needing to go into the emergency room are those who have higher needs and should be there. Second, given the requirements for network adequacy and access, we have seen our health plans facing challenges in negotiating rates with facilities and other providers, particularly when there aren't an abundance of certain types of providers in the geographic region. Since our plans need to ensure access to services, they at times have had to end up raising their rates by 10, 15, or even 20% or more with certain providers. And those costs, of course, translate into higher capitation rates for our program and higher Medi-Cal costs overall. Second, and I know others will touch on this as well, we are seeing significant cost increases with respect to pharmacy, given the new and ongoing entrance into the market of certain specialty drugs that are extremely high cost. We are just starting to see the impacts of some of these new drugs, but we know from experience that specialty drugs are costly. For example, of the 12 drugs that were approved by the FDA for cancer use in 2012, 11 of those drugs cost more than $100,000 per year. There's a drug that targets the molecular defect for cystic fibrosis, and it costs over $300,000 a year. And has been widely discussed, and I know others today will address it, the recently released hepatitis C drugs can cost anywhere from $63,000 to almost $200,000 per course of treatment. While there have always been high-cost specialty drugs, one of the things that's changing is that typically those were for more rare diseases. And so with the release of the drugs, particularly around hepatitis C, we are seeing them apply to sort of broader populations. And so that is driving sort of costs at a much higher rate than we've previously seen with specialty pharmacy drugs. One of the unique challenges faced by Medi-Cal being a Medicaid program is that we have certain federal requirements that prevent us from instituting some of the potential cost containment measures that other payers might be able to institute. For example, federal statute requires that Medicaid programs cover all FDA-approved medications as soon as they're available in the marketplace, unless specifically excluded from coverage through the Social Security Act or through a change to our state plan. Now, while in the past, CMS has approved waivers and exclusions for certain specialty drugs as long as there were other drugs available for that treatment, the indications coming out in the last few years is that those types of waivers are typically not going to be approved in the future. So I'll just close with a note about what DHCS is doing in terms of looking at how to improve cost containment while still ensuring that our population has access to high quality care. California has embraced managed care because we believe an organized delivery system and an entity who is responsible for ensuring care coordination and management leads to better outcomes and lower cost. And we believe the evidence demonstrates this. We have seen changes in utilization patterns and reduced preventable or unnecessary high-cost services and increases in ambulatory care and improved health outcomes. As we look to the next 5 years, and as part of what we're exploring in our Medi-Cal renewal waiver, we are looking to move even further along that spectrum with a focus on whole person, integrated, and coordinated care, and moving away from cost-based or volume-based reimbursement methods to ones that are focused on value and risk. And while there will continue to be drivers of cost that may not be contained fully by these efforts, we do believe it will help in contributing to the overall cost curve.
Thank you. What I'd like to do is, if you don't mind, I'd like to have you stay there, but if we can call the entire panel up from section number 2, that's Ian Lewis, Research Director, Unite Here Local 2, Jim Araby, Executive Director, UFCW Western States Council, Amy Shin, CEO Health Plan of San Joaquin, Doug McKeever, Chief Health Policy Research Director from CalPERS, Samir Aswar, MD, Associate Executive Director, Pharmacy, Adult Family Medicine, Kaiser Permanente. And then what we'll do is we'll go down the list, have each one give their presentation, then we'll open it up to questions to the members while everyone is up here, if it's okay with the committee. So we're now going to move on to the second individual. That's Ian Lewis, Research Director of Unite Here, Local Number 2. Welcome.
Thank you, Senators. Is this on?
Now it is.
Thank you. So my name is Ian Lewis. I'm Research Director at Unite Here, the Hospitality Workers Union. Our union represents in California about 50,000 hotel, gaming, restaurant workers. And throughout the US and Canada, we represent about 250,000 hospitality workers. And the juxtaposition between the members we represent in Canada and the US on healthcare in particular is incredibly informative. I think it's safe to say ours is the only country where the Hotel Workers Union would have much to say about healthcare delivery and costs. As it is, we devote enormous resources to trying to make sure that workers' healthcare is managed to maximize quality and in a way that contains costs so that we don't have to slash access to services in order to maintain affordable plans. That has become increasingly impossible to do in our industries, frankly. I want to say a word about our membership. Housekeepers, dishwashers, cooks, bussers, overwhelmingly immigrants who came to our state on the faith that if they worked really hard, they could put their kids, position their kids for a life that was impossible for them, for their parents. They're not high-income earners. Most, at least on an income basis, would be eligible for Medi-Cal. And as a result, winning the funds that it's necessary to maintain good quality health care is an extraordinarily difficult proposition. Our members have said time and again that this is the foremost priority, even though every penny that goes to maintaining health plans is a penny less that goes into their pockets to pay for increased rent, childcare, and so forth. And it's also the result of huge instability in our industry's labor relations. Every single strike, lockout, boycott that we've had in the hospitality industries over the last decade has been about healthcare costs. The most recent 1,000 restaurant workers at SFO just in December is just the most recent example. And California is not alone in this cost crisis. Cost crisis is a national one, but California has been outstripping the rest of the country. Over the last 20 years, we've seen California go from a middle-of-the-pack state in terms of healthcare costs to one of the most expensive markets in the country. And as a result, it's hospitality workers, service workers in general that are increasingly being dumped into Medi-Cal, onto other state-funded programs, and into the ranks of the uninsured. I want to dispense with a couple of the myths about cost drivers first. It may be true that America's population is aging. Ours is not. Our members' age has been just about constant for the last 20 years, and we secure the health care for over 100,000 people in California, and the average age of that population hasn't changed. Nor are we getting sicker. In fact, on a case mix suggested basis, our membership is a little bit healthier than it was just a few years ago. And we're not overutilizing diagnostics and procedures. In California, the overwhelming majority of our members are enrolled in managed care plans, which actually do a decent job at regulating when people are given access to the most expensive procedures. And where there is inappropriate utilization, for example, access of ERs, we are able, because we're focused on this issue, to intercede and work with our members to redirect them to the appropriate sites of care. The problem is unequivocally the relentless rise in unit costs. And we'll talk some, or we'll hear some about prescription drugs, and they are a great case study for this, particularly the patented drugs. The drug prices in general here are 60% higher than they are in the largest European economies. The 30 most commonly used drugs are over 30% more expensive in the US than they are just to the north in Canada. And what differentiates us from other countries, other markets, is that the state here has not taken an active role in regulating those prices in a way that manufacturers can recoup appropriate profits, but that access to essential services and drugs isn't made impossible, that people's care isn't jeopardized. And again, the case study on Hep C drugs at the moment couldn't be a better example. Just to put bluntly, Kaiser Permanente's entire enrollment is about the same as the entire population of Sweden. It is twice the population of British Columbia. The fact that health plans of that size have a hard time negotiating affordable rates for these kinds of services goes right to the heart of the problem. And you can extrapolate what kind of a challenge so-called large group payers like us have in negotiating decent rates. I do want to put drug prices in perspective, though. For Unite here, nationally, drug prices are just about a little less than 20% of the overall trend. In fact, in California, we have a little less transparency as to cost drivers, although that's improving through the effort of your committee and recent legislation. But we think it's actually, the drug problem is actually less in California than it is in other states. Again, what's interesting about drugs is that they represent the broader problem. Facility fees are nearly half, well over 40% of the overall cost driver for our plans. And as with patented drugs, the concentration of market power in just a few hands means that open market negotiation over rates are not an effective way to control rates. And I'm sure you'll hear more about that shortly. I would assert that increased competition is not the ultimate solution to the facilities fees problem or any other problem in terms of healthcare cost drivers. Given the capital intensity of building facilities or investing in new drugs, California doesn't need duplication of services. In fact, Unite here grapples with the reverse problem just across the border in Nevada in much more competitive markets where there's a surplus of competition. You have massive one-upmanship by providers in acquiring the latest, greatest machinery and devices, which drives up the cost trend for the market as a whole. I do think California needs much greater transparency in terms of pricing, but not just pricing. We need greater transparency as to what the underlying cost drivers are for providers, and where there is a mismatch between a community's needs and what the break-even cost of meeting those needs is for providers, and what the rates are that are being charged for those services, that the state needs to play an active role in making sure that those communities have access to that care. The other big cost driver, of course, is physician fees, and they make up another 25% of our overall trend. We know collectively that the US spends about 5 times what other OECD countries spend on physician services, and yet we use the doctor less. Again, very similar problem to facility fees, and it's a segment of the healthcare market that's consolidating very rapidly. And as with hospitals, consolidation in and of itself isn't inherently a bad thing. Larger physician groups are able to streamline administrative operations, support much more coordinated care. The challenge is when that consolidation leads to monopoly practices that we need to keep a strong eye out for. So just to conclude, our union's health plans have undertaken a great deal of work in managing the utilization side of the equation. In LA, we've partnered with managed care organizations and others to assist workers and their families who suffer from chronic diseases to manage their conditions most effectively, navigate the healthcare system more effectively. Elsewhere, we've gone so far as to open our own clinics so that workers in our industry have access to the kind of care that's appropriate to their demographics and unique membership traits. But utilization is only one piece of the puzzle, and frankly not the one that's spun out of control. Drug prices, facility fees, physician fees make up 85% of our trend. And this crisis, as you know, is coming to a head now and in the next couple of years. So as the ACA, for all the great things it does, as it rolls out, it imposes a 40% punitive excise tax on plans like ours once we pass a certain threshold. So we're getting pinned between a rock and a hard place, and unless we can get control of these unit costs, we're going to see millions more people being dumped out of the employer-based healthcare system into Medi-Cal and other publicly supported programs. I do want to acknowledge the extraordinary work that your committee and the legislature has done in the last session, in the last few years, on the subject of transparency. I think because of this, we're going to have a much clearer picture about what's driving healthcare costs in California, but time's running short, and our state needs to do more and more quickly. So thank you again for keeping the focus on this issue.